Thank you. Please give me a shout out if it's visible to you at the moment. Are the slides visible?
Yes, sir.
So this is the topic, residual risk odyssey from LDL to lipoprotein A. And this was actually published in 2021 as an editorial comment in the Journal of American College of Cardiology by Robert Rosenson. And I'll come to the significance of this particular topic in a while, but just to set the context, we know that atherosclerotic cardiovascular disease is the leading cause of death, and despite significant advances in the treatment of atherosclerotic cardiovascular disease, we know that it remains the leading cause of death and disability worldwide. And the traditional risk factors for ASCVD would include hypertension, diabetes, elevated LDL cholesterol levels, along with smoking, obesity, and family history of atherosclerotic cardiovascular disease. We also know, since the advent of statins and the discovery of statins, it has remained the cornerstone and one of the pillars of treating atherosclerotic cardiovascular disease. Because of the cost effectiveness, it has become absolutely indispensable. And management of risk factors is absolutely crucial in the treatment of ASCVD. And among the risk factors, elevated LDL cholesterol seems to be one of the principal drivers of atherosclerosis, and there is a linear co-relationship as well. So LDL-centric approach, namely the statins that we know about, has served as the foundation for primary as well as secondary prevention for decades and led to significant improvements in the cardiovascular outcomes. Now the point remains, is that good enough just to target the LDL cholesterol? Now we know that it's easier because LDL cholesterol is something that we can do in every single lab. And there is a positive correlation between the elevated LDL cholesterol levels as well as future cardiovascular events and atherosclerotic cardiovascular disease risk. Now, if we are addressing and hitting the LDL cholesterol hard and bringing down even below 70, we do see that there is a residual risk that remains, and that is going to be the topic of discussion for today. Now, when the LDL cholesterol remains more than 70, even despite using maximum tolerated statin dose, there are indications to use a non-statin agent, and that can be of various mechanisms. So one of the things that are considered based on the cost per se would be something like ezetimibe, and it's a Niemann-Pick C1-like transporter inhibitor, and it blocks the absorption of the dietary and the biliary cholesterol and the plant sterols. Or we could think of something like a human monoclonal antibody inhibitor. And the commonly used one is, of course, the one that you see on the screen. So proprotein convertase subtilisin kexin type 9 inhibitors, or commonly known as the PCSK9 inhibitors. And the prototypes are alirocumab and evolocumab. Now, these are the second-line cholesterol-lowering treatment, which help achieve LDL cholesterol targets, which was not achievable by the statins alone. And these are the ones which work by enhanced LDL receptor-mediated clearance of the LDL and other atherogenic lipoproteins. Now, what do we mean by the residual cardiovascular risk? So certain trials demonstrated that despite the significant reduction in the LDL cholesterol, as we were saying, even up to say 30 to 40 mg per deciliter, with even PCSK9 inhibitor-like agents, which has got the capacity to robustly decrease the LDL cholesterol levels, we do see that there is a risk reduction, which was modest with slight high event rates. And this could be because of the residual cardiovascular risk, and there could be multiple drivers of this residual risk, which might not be directly addressed through the current treatment strategies using statins. The residual cardiovascular risks could be because of the residual inflammatory risk that remains, or the residual metabolic risk, or even the residual thrombotic risk, which are related to something called the lipoprotein small a. And the related gene to lipoprotein small a is the Lpa gene, and it comes in about 40 isoforms, beg your pardon, and so you see a lot of heterogeneity when it comes to this particular molecule. So lipoprotein small a is an LDL-like particle containing apolipoprotein A linked to apolipoprotein B, as you see in this structure. And several studies have now evidenced an excess of Lp small a, an independent risk factor for ASCVD events. So over on top of addressing the LDL, probably there is a need to address this Lpa as well, because we know that Lp small a might promote atherosclerosis and thrombosis and also increase the coronary risk. What are the mechanisms? So it can drive atherogenesis through a myriad of mechanisms. And one of the things that are proposed is probably the suggestion that Lp small a is the primary lipoprotein carrier of oxidized phospholipids. And these oxidized phospholipids are a danger-associated molecular pattern which is recognized by receptors on the innate immune cells, which triggers inflammation, which triggers thrombosis, and also plaque destabilization. And surprisingly, large impact of the Lpa compared with LDL-C on the ASCVD risk suggests that it possesses other pathogenic properties as well. This diagram elaborates what we were trying to say in here. And as you can see in here, lipoprotein A can drive immune cell activation, increasing the reactive oxygen species. It can drive inflammation. It can drive endothelial cell activation, increase the prothrombotic agents, increase immune cell recruitment. It can also act by driving platelet activation, increasing aggregation degranulation, and thus drive atherogenesis, and finally, plaque destabilization. What about the Lp and cardiovascular risk? We know that Lp small a is highly a prevalent cardiovascular risk factor with levels more than 30 milligrams per deciliter, affecting 20 to 30% of the global population. And three major levels of evidence support the notion that elevated Lpa are a causal independent genetic risk factor for cardiovascular disease. And this comes from epidemiologic studies and meta-analysis. It comes from genome-wide association studies and also Mendelian randomization studies. Lp and cardiovascular risk. So this comes from meta-analysis of almost 29,000 statin-treated patients with high baseline ASCVD risk. And what we have seen is that as compared to those who have a baseline Lpa mass of less than 15, compared to those who had Lpa more than 50, they were associated with at least 42% higher risk of future cardiovascular events. Similarly, the Inter-Heart study showed that anyone with the Lpa level of more than 50 milligrams per deciliter was also having a 48% increased risk of having a future myocardial infarction event. A sub-analysis of the Jupiter trial demonstrated that Lpa was a strong predictor, which was associated with 27% residual risk, independent of the LDL cholesterol and other risk factors. This Fourier trial, which means further cardiovascular outcome research with PCSK9 inhibition in subjects with elevated risk. Again, 25,000 odd patients with established atherosclerotic cardiovascular disease were looked into, and patients with baseline Lpa concentration, which was in the highest quartile of more than 165 nanomoles per liter, versus those who had Lpa levels very less than 13 nanomoles per liter. There was a 22% higher risk of coronary of a cardiovascular related death, MI, or urgent coronary revascularization. Fourier trial also showed that patients who were treated with evolocumab versus placebo for 48 weeks Evolocumab not only decreased the Lpa concentrations by 27%, but it also reduced the risk of major coronary events by almost 23%. It also showed that there was a stepwise decrease in the risk of major coronary events for patients who achieved either a Lpa or a LDL cholesterol value below achieved median, and the lowest event rate was observed for those individuals who achieved lower levels of both Lpa as well as LDL cholesterol. So anyone, and we are trying to drive the Lpa, and the median drive was to around 12 milligrams per deciliter for Lpa, and LDL cholesterol median was around 65. So somebody who was achieving both low levels of Lpa as well as LDL cholesterol, they had the maximum risk reduction. And as you can see in here, lowest event rates was seen, 28% lower risk of major coronary events with both. So Odessey outcomes, evaluation of cardiovascular outcomes after an acute coronary syndrome during treatment with alirocumab. Again, 19,000 odd patients with recent ACS on high intensity statin therapy was looked into, and alirocumab reduced Lpa by 23%, LDL cholesterol by 51 milligrams per deciliter, and risk of MACE was reduced by 15% versus the placebo. So there was a linear relationship between the Lpa and the cardiovascular risk, and in the placebo group, participants in the highest compared to the lowest baseline quartile of the Lpa show that there was 46% more likely to experience MACE in the high quartile as compared to the low quartile. Similarly, there was a 54% higher chances of experiencing non-fatal MI or cardiovascular related death in the high quartile versus the low quartile. The results indicated a linear relationship between a baseline Lpa level as well as the risk of 3-point MACE. Odessey outcome trials show that higher levels of Lpa more than 13.7 milligrams per deciliter was also associated with the higher cardiovascular event rate, regardless of the LDL cholesterol level. So whether the LDL cholesterol was driven below 70 or even stayed over 70, didn't matter. As long as they had a higher Lpa level, it was independently associated with a higher risk of cardiovascular event. So additionally, PCSK9 inhibitors like alirocumab decrease the cardiovascular events, the subgroup of patients with LDL cholesterol below 70 even, and those with the Lpa of more than 13.7. So alirocumab induced reductions in the Lpa and corrected LDL cholesterol content of the Lpa, independently predicted the lower risk of total cardiovascular events. And what we did see was each 5 milligrams per deciliter reduction in the Lpa predicted a 22.5% reduction, relative risk reduction in the cardiovascular events. And the results of the Odessey outcome trial suggest that Lpa should be an independent treatment target after ACS. Let's look at what the guidelines say. The AHA-ACC 2018 guidelines recommend that anyone with family history of premature atherosclerotic cardiovascular disease should be screened, or personal history of ASCVD not explained by major risk factors, and anyone who is an adult aged between 40 and 75 years of age without diabetes and intermediate risk for ASCVD, you need to target the Lpa to 50 milligrams per deciliter or less. Similarly, EAC or EAS 2019 says that Lpa measurements considered at least once in each adult's lifetime to identify those with very high Lpa levels more than 180 with lifetime risk of ASCVD, and should be considered for selected patients with a family history of premature cardiovascular death, and for reclassification who are borderline between moderate and high risk. So initiate moderate to high intensity statin in adults aged 40 to 75 years with a 10-year ASCVD risk of 7.5% to less than 20%, and target Lpa and anyone with a baseline Lpa of more than 100. Similarly, high-risk patients with the LDL cholesterol more than 70 and Lpa of more than 100 on maximally tolerated statins should be considered for more intensive therapies like ezetimibe and PCSK9 inhibitors. And now we are having ongoing trials with the novel agents which target the Lpa, and they are in the phase 3. And one of such molecule is TQJ230. There's some interesting research that is coming up, and it's based on the antisense, of course. Another thing that I wanted to highlight was, the level of OXPL that we were talking about earlier, apolipoprotein B containing lipoproteins, primarily the Lpa, was found to be highly predictive for future atherosclerotic cardiovascular disease. So Accelerate study is something that showed that anyone with higher hsCRP levels and high levels of Lpa would have higher chances of a future cardiovascular event. So there's a lot of ongoing research to identify markers other than LDL cholesterol for atherosclerotic cardiovascular disease related cardiovascular deaths. And LDL cholesterol-based approach has remained the foundation for ASCVD management. But even after significant LDL cholesterol reduction, there is a high prevalence of cardiovascular events indicating residual cardiovascular risk. Lp(a) has been found to be an independent cardiovascular risk factor promoting atherosclerosis, and several meta-analyses along with the recent major trials like the ones we were talking about, Fourier and Odessey, have proven that elevated Lpa levels increase the risk of cardiovascular events irrespective of the LDL cholesterol, even when you have driven the LDL cholesterol levels less than 70. The Fourier and Odessey trials also showed that significant reduction of the Lpa levels with PCSK9 leads to reduction in the risk of cardiovascular events, and there is ongoing research with the novel Lpa, novel molecules which are targeting the Lpas in particular. So Lpa is a strong predictor of cardiovascular risk and should be considered as an independent treatment target. And that remains the key takeaway from our talk today. Thank you so much for your kind and patient hearing, and back to the chairperson, please.